When conditions allow, the patient-centered benefits of immediacy, such as gingival contour preservation and reduced morbidity, makes this approach the treatment of choice. And that's what I'm showing you on this webinar, streamlining soft tissue conditioning in the posterior region with Straumann Fast Molar Solution and anatomic healing abutment. I believe this short, case-based webinar will be worth your time. Enjoy! And we start this webinar already in a practical way. This is a case from our colleagues Algirdas and Victoria from Lithuania, immediate implant placement in the posterior mandible. When we look at these images, these clinical images, we see the molar that was hopeless, needs to be extracted. So the root was sectioned, and then the roots were extracted and the implant was placed. And the next thing we see is how normally surgeries are concluded. You place a healing abutment, you make single sutures to bring the tissues closer to protect that wound. And as the healing goes by, when we remove the healing abutment, that's what we see. It's a very beautiful healing process. Here comes the interesting part, because as you notice, the healing abutment has this flaring following the emergence profile, but then it comes up very cylindrical. After this site has healed, when we look at the picture on the left, you see the conventional shape of the healing abutment, fully round. We need to keep in mind that the future crown won't have that shape, so this soft tissue needs to be conditioned. How do we do this? We do it with temporary prosthesis. Now, with the temporary crown, we see there's already also a mismatch. When we look at the purple healing abutment versus the shape of the temporary crown, there's a clear mismatch. That means the soft tissue will have to be conditioned proportionally to that white shape. This comes with some discomfort to the patient. So every time you do that quarter turn with your driver, the patient will feel it. How do we bridge this? Some clinicians are doing the customized healing abutment. The first way we commonly see is in the analogic way. You see the abutment being inserted onto right on top of the implant immediately after the surgery. And then what you see next, the clinician is applying light curing composite to seal that socket. Later he removes this and then also shapes the emergence profile. All this procedure can be quite costly because you will need a temporary component, you will need an analog, and then eventually towards the final prosthesis, you need to take an impression, a digital impression or not. But if you take a digital impression, you will need a scan body to then transfer this information towards the final prosthesis. But now shaping this part individually by itself can take up to 30 minutes, 40 minutes. And if you have multiple teeth, then can take up to an hour and a half. That is very time consuming. And all these sessions, the different sessions that you have to go through, will give a much longer time to teeth that your patient expected. What is also commonly done is via digital workflow. It's another option too. So right during the planning, you already considered this route. So all you're going to do, instead of manually shaping this in chair side, you're going to design it in a software, and then you're going to have to cement this to an abutment. However, increases cost, because keep in mind, you're going to have an abutment, and then you need something to mill and cement onto this abutment, and invariably towards the end, you're going to need a scan body to scan that site. So you have to remove also this part, scan that site, and then shift towards the final prosthesis. Again, this increases cost, this increases also a lot of chairside time, and increases the overall time to teeth, which also the patient is a bit anxious about. Now, the alternative that is state-of-the-art is the anatomic healing abutment. This abutment combines a whole lot of benefits in one component. First, it starts with the torque fit connection. It's a state-of-the-art connection present in the IXL line. Second, you have the emergence profile that matches the consistent emergence profile from healing abutments, from temporary components, from the Vario base. So they're all matching no matter which part of the treatment you're at. You're not going to disturb the soft tissue. And on top of this, you already have this predefined emergence profile that will be similar to the emergence profile to your final crown. So you won't have all the push and pull from smaller component migrating to a soft tissue conditioning. So the shape is already predefined. So once you place it, your soft tissue will heal all around this. And when you transfer this information to the lab, it's already just like replacing the wheel of a car because the shape is pretty much the same. The other advantage is the scannable head. So remember, we discussed that all of the steps previously done, you would have to remove all the work that you did in the analogic way or with the digital workflow, like the case from Nikolai Makarov, for example, and to place a scan body to scan it. Finally, the anatomic healing abutment combines all the anatomical features with a state-of-the-art connection and the scannable head, so you don't have to remove this component when you go forward towards the final crown. Now, looking at this slide, you can see clearly the difference. We keep the consistent emergence profile at the base of the component, but the flaring already gives the emergence profile of the future crown. You see, when we overlap the components with the healing abutment, with temporary abutment migrating towards the final crown, it matches, including the emergence profile of the gingival height, but already gives the emergence profile of the future crown. This is a huge benefit that your patient will never suffer anything when you remove this component to place the crown. I would like to walk you through some of the patients that I treated with this solution, with the fast molar solution enabled by the anatomic healing abutment. This is median. This is the initial consultation. Even though it's a second premolar bilaterally, it's still within her smile line. We bring to a closer look, see how she has this shy smile because she knows it's already missing a premolar on the lateral side and a premolar on the right side. When we look at the occlusal view, you see clearly the number 15, it feels like a healed site, it resembles like a healed site, but hold on, I have a surprise for you there. And on the other side, you have tooth number 25. That is already a hopeless residual root. It needs to be extracted. And then we move to the data acquisition. It's really important that you collect all information possible for a more precise planning. The next element necessary for the data acquisition is the CBCT. The CBCT will give you all the bone information, all the anatomical information that in combination with the scan file that you just collected previously, this will give valuable information towards the planning. Planning options. How can you get there from point A to point B? You can either do it yourself. If you're familiar with the software, with co-diagnostics or planning softwares, you can do it yourself, or if you have somebody in-house as well to do it for you, or you can outsource it to Straumann Smile in a Box. This is an outstanding service in which was the route that I chose. So what I did is to type www.straumann.com, scroll down to where you find Smile in a Box, that you click order a case, and you're good to go. Now, all you have to do is select the region you are, the country you are, and then fill in your personal information, the information of the patient, if it's your first case or not. And after you did this, it's very easy. So you start inserting the patient information. So you're going to select the implant system that you're going to use. Then you're going to select the sites that you're placing those implants at, or you want that planning to happen. And you give the information if it's a single crown, multiple crown, or full arch. You will also give information if you just want the planning. If you want the planning plus the design of the guide, if you want the planning, design of the guide, but also the printing of the guide. And next thing you do is you will upload all the scanning files and the CBCT right into the server. Once it's uploaded, that's it. That's all you have to do. You just sign it and submit. Once you submit, the Smile in a Box team will call you. That's very convenient. They'll call you the next day already with a preliminary planning based on the information you provide. They will call you because they would like to make sure they best serve your needs. So you're going to fine-tune that planning with the Smile in a Box team. They always start from the top-down planning, so they see what will be the correct prosthetic position that you will best match this patient condition. Once you have sorted that need, then you go one step lower and you start allocating how the implant is going to be positioned, what the implant diameters are going to be possible to be used. And also you see on the left already, including in the planning, the anatomic healing abutment of choice, because those two implants are going to be placed and the anatomic healing abutment we're planning to insert in there. So this patient goes for healing without having to be temporized with all the push and pull of the tissue later. We also ask them to design the guide, because we're going to do this surgery with guided surgery for a more precise placement. So you see the guide has been designed, and next thing you know, a box will be sent to you. And when you open, you see the planning that you ordered. You will receive also a box with the guides, because we ordered the planning, the design of the guide, and the guides. We also ordered the models. And you will receive Co-Diagnostics exported planning, so you see all the anatomical details of this planning. And you will receive also the surgical protocol for the guided surgery, which is really important. You see that it's been defined, the surgical drilling protocol, precisely for tooth number 15 and the drilling protocol for tooth 25. Now let's get practical. We also opened the box. I ordered the model and I ordered the guide. The reason I ordered the model is exactly to see if what I wanted to check in regards of guided surgery, if it fits the model, if there will be any interference during the surgery that I need to be aware, that I need to work so the guide fits precisely. So I checked, and here how the surgery took place. So you see on the number 15, as I told you, there will be a surprise. On the CBCT, I noticed, even though it looks like a healed site, I noticed there was a residual root trapped underneath that soft tissue. The tissue looks pretty good, but there was a residual root there. So in that case, I made a crestal incision, I opened the flap, and then I started with the procedure to remove that root out. On tooth number 25, I did a minimally traumatic extraction with a periotome to release that as much as possible. But unfortunately, the tooth was too compromised. It was breaking. What I had to do is to go with the burr gently around that root in order to remove it. But then I was able to extract that root and finally proceed with the implant placement. Now with the guided surgery, that's a different story, because now makes it very simple. All the challenges we had in the surgery to extract was far higher than the implant placement itself. So now moving to the guided surgery, you see bilaterally following the drilling protocol, the pilot drill being first, and then next, the 2.8 drill as defined in the drilling protocol. Very simple, no complication, very straightforward procedure. And for the implant placement itself, you see bilaterally, they were all seamless. I was able to insert the driver perfectly through the guide, and both implants on tooth number 15, on the site 15, 35 Newton centimeters, and on a 25, almost 50 Newton centimeters. So this gives us a lot of peace of mind that we can even temporize it if we want it. So we're safe that stability, primary stability, is granted. We proceed to the gap management. Remember, those are extracted sites. There will be a gap between the implant and the buccal wall. So we want to graft that site as much as possible around to maintain volume as much as possible. For this, we use the Cerebone Plus. With a small hydration, you already get this sticky effect that is very easy to manipulate. And you see on the below images that is very easy to transport to the implant site and apply around the gap. Next thing we do is we selected the anatomic healing abutments. Remember, already consider in the beginning in the planning, we placed the medium healing abutment, medium size healing abutment on tooth 15 and also on the tooth 25. You see that it seals already the socket very beautifully. But look how these two sides, even though very different, one had an incision and the other one was a flapless extraction with immediate implant placement, I was able to bring the tissue back and suture with single sutures mesial-distal on both sides, and this is how the patient goes home. And in 2 weeks post-op, what we see is a very loose suture that tells there is no signs of inflammation, no tension on that suture. You can also see how pinky this healing process is turning to be. If there's no bleeding, no signs of inflammation, that means the coexistence of the tissue and the device is working really well. After we move towards the 8 weeks, we start scanning that site again. You see that it goes really well. the scanning properties of the anatomical healing abutment. And when you transfer this to the planning, to the designing software, you see the predefined gingival height that is right connecting to the implant is preserved. All you have to do is to give a little bit of a fine tune at the emergence profile of the crown itself to match precisely the design of the anatomical healing abutment. So when you remove the anatomical healing abutment to place that crown, your tissue barely won't even notice, because you're going to remove a shape and place another shape that is precisely copy and paste of that design. Soft tissue will just love it. And now what you see are already the restorations done by the lab. And clinically, that's what we want to see. When we remove the anatomical healing abutment, we want to see that beautiful, pinky, emerged soft tissue healing. Look at this. It doesn't get any better than this. And when we insert the final crown already directly, because there's no reason to temporize this, because the shape is already defined by the anatomical healing abutment, we place the crown, torque 35 newtons, and that's it. You see the opposite side, side 25, same thing. We remove it, even though it's very early healing with only 8 weeks for the final restoration. Look at the soft tissue conditioning. It's ready, waiting for the final crown just to be seated. No additional component needed, no hassle, no scan body needed. It's state-of-the-art streamlining soft tissue conditioning. We check the occlusion and the patient is happy. So if we go 60 days healing, 8 weeks, this is the condition we see. We see tooth number 15. Remember, we made an incision and you still see the incision line there. But nevertheless, the emergence profile that was granted with the anatomic healing abutment, look how beautifully already shapes, giving space for the final crowns to be seated. I would like to walk you quickly through the second patient. This patient is a molar site. Please meet Giovanna. She has tooth number 16 that is hopeless. In her smile line, you don't see anything because it's already further back, but nevertheless, this compromises her chewing performance. She would like to do something about it, and that's when we thought it would be an ideal candidate for extraction and immediate implant placement. So again, we start with a top-down planning with the crown, with the restorative design in mind. From that moment on, we start thinking how the implant will behave in that context, which implant we're going to use, what position, how we're going to engage. And next, we already moved with the desired shape of the anatomical healing abutment. So you can see the overlap in the central bottom image, the overlap of the anatomical healing abutment versus the desired shape of the future crown. And also in the CBCT, we can overlap, also seeing buccolingual, how is their relationships going to look like. We also designed the guide, providing the windows to observe if the guide is properly fit. And with this, we get also the co-diagnostics planning. And with this, we start the surgery. It's a first molar, it's triple root. So we start sectioning the roots in 3 parts. Then I remove one of the segments, then I remove the palatal segment, and that's what you see at the bottom right. The tooth already extracted, so we have a big septum to play with. I position the guide, and again, very straightforward, and I started with the drilling protocol. We're going to follow the soft medium bone because we're going to be in the septum, soft condition, and the implant will be primarily engaged in its apical part. Then it's time to place the implant. I did the pickup with the implant driver for guided surgery, exactly at the mark that was predefined in the planning. You can see that we reached 35 to 50 newtons. I was very happy then to continue with the procedure. And remember, it was a extracted site, so we want to manage that gap to minimize soft tissue and hard tissue collapse. We used again the Cetabone Plus with hyaluronic acid. That makes very easy, just small drops. It hydrates very easily. It's easy to scoop, very sticky characteristics, so easy to handle and pack onto the gap. And next thing you see, the anatomical healing abutment for molars. That means the XL on the driver, middle image. After I just placed onto that site. What we did, because during the extraction was quite some bruising and some tissue damages there, so I did some small sutures, small single sutures, just to keep the tissue in place. And then 2 weeks healing. Again, the sutures very loose, the tissue behaving and coexisting with the component very nicely. As we move forward with 6 weeks healing, the behavior of the soft tissue in harmony with the component, this gives a lot of peace of mind for us to move forward with the restorative steps. Now we start again, scanning. So it's very easy. You notice during the scanning procedure that the scanner recognize the anatomic healing abutment very easy, so you can transport this to your planning software to design your future crown. This is already in the design software, and what you see on the right side, again, similar to the first patient, we're going to move this sideways, so there's a predefined shape of the gingival margin, just that emergence profile that we see already at the crown level, that we're going to do some fine tuning, so the new crown will never push and pull the soft tissue. It will be matching one-to-one the anatomic healing abutment and the shape of the future crown, and this is what you see from the occlusal view. As we shift that design to the lab, during scanning, what you also do, you take a picture with your shade palette. In this particular patient was A2, A3, and A3.5. This was shifted to the lab technician who started doing the artwork of the shading to best match the patient's overall coloring. All the lab work is done. It's time to get real. Again, it doesn't get any better. Look at this. When we remove the anatomic healing abutment and you see that soft tissue conditioning, it's beautiful. It's medtech technology applied to the greater good to serve the patients. Then we torque in 35 newtons, we do all the occlusive adjustments, and then fine-tuning with the occlusive adjustments, and that's it. It doesn't get any better than this. Looking at this workflow at the beginning and how the patient was finalized, how efficient, how cost-effective, how low morbidity this took, it makes the anatomic healing abutment and the fast molar solution my route of choice. I was lucky enough and privileged to count on the support of colleagues, Dr. Dalton Marques from Brazil, Gustavo Fazano, and the amazing work of Tiago Tomé doing all the lab work. And this was done in collaboration with Elapel University in Brazil. And I could not thank enough all the amazing high-performing team of nurses, assistants, and the radiology team that support us all the way throughout this clinical validation. On this note, I thank you very much. And if you have any questions, feel free to write on the email below. Thank you.